The next talk by Dr. Satish Govind, is Chief Non-Invasive Cardiology at Narayana Institute, Bangalore, and he is going to say that for valvular heart disease, echo is best. I think he has a vast experience and is going to discuss about the role of echocardiography in valve assessment. Over to you, Dr. Satish.
Thank you very much, chairpersons, and good afternoon to all of you. So first and foremost, thank you for the kind invite, the association, Dr. Vimal, Dr. Priya, Dr. Pudi, for this invitation. And as somebody representing the Indian Academy of Echo, I think we are very honored and it's a real great pleasure to be associated with your association. And we want to continue with this and look forward to more, better years in the years to come. Now, coming to the topic itself, we had a wonderful talk by Dr. Johan, and he sort of emphasized on the various aspects of MRI. So I'll be looking at it from the other side. How does echo fare in terms of the valve assessment? Now, when you are looking at the echo itself, there are many parts of the echo. So it starts from transthoracic, and then it moves on to transesophageal echo. Then we have stress echo, dobutamine stress echo, exercise stress echo, and then we have 3D strain. And in a very limited way, contrast also is sometimes used. Now, to set the tone itself, if you look at the comparisons here in terms of echo and the CMR and CCT, so you look at the valve itself. So it has got a 3-star rating. So that itself sort of tells you that echo plays a big role. Now, let me sort of look at the expert documents. You have a lot of these societies who have come together and who have sort of, set the criteria, what they call as appropriate criteria. So it's a very busy slide, and I'll be continuing to show these very colorful slides. So just to make sure that it's, since it's so busy, I'll just sort of, to make it very clear as to how you can look at it. Just ignore those small alphabets over there. Green means it is appropriate, red is rarely used, and then you have the M, which is yellow, which is the mid one. So anything green is good and red is not so good, and the M yellow is in the middle. Now, the use of echo starts from the asymptomatic patient itself. So you can look at the indications here. So many times just clinical suspicions, features, signs, or any other family history, that itself is enough to sort of initiate echo. So echo is the appropriate tool starting from the asymptomatic patients here. Now we go to a lot more busy slides here. So you can just again, as I said, like ignore a lot of these alphabets and text. Just look at the colors here. And the top row here, you have transthoracic, and then you have T here, and then 3D comes stress echoes, and then you have the PET, CT, MR, and the other ones here. So look at the indications here. When we look at the indications, you have arrhythmias, you have the presentations, which can come in so many ways. You have syncope, the failures, hemodynamic instability, the heart failures, and then you have bacteremia in terms of endocarditis. So at every given point of time, you will see this yellow and green. So that is transthoracic. So it is again the first line imaging here. Now, when you come to inadequate transthoracic images, many times window is a big issue. So then we sort of fall back on T's and sort of in a very limited way, sometimes contrast help, but most of the time it is T itself. And when it comes to valvular masses, again, transthoracic and the TD is very helpful here. Now, the next part is looking at the valve lesions itself, as was enumerated earlier. So I have mitral stenosis. We have these time-honored techniques, and these have been there for many decades and continue to be the backbone, and they are very dependable. And we have the 2D, the color, and you have the Doppler over there. And with the advent of 3D, we now have the benefit of looking at it in orthogonal ways. So we are getting our accuracy in terms of the mitral orifices much better. And the 3D has further sort of, the actual 3D image has made it even more accurate. So this again is useful in terms of both transthoracic as also in terms of TE. And here you can use the transthoracic provided the window is good for looking at complex orifices here. Now, T also is very frequently used, and you can see that we can get a very good look at the appendage, and you can identify the thrombus here, and there's a lot of smoke here, what we call as spontaneous echo contrast, and then looking at the valve itself, and then looking at the quality of the atrial septum, because many times we want to look at it in terms of punctures, so the quality of the septum is also looked at when T is being done. And when you add the 3D, so now you have an on-fast view. And again, we sort of look at complex orifices where it is very helpful here. So this is where the echo really sort of helps in terms of scaling up from TT to T itself. Now, there might be some discordances. There might be some sort of clinical dilemmas. So here we have the green in terms of trying to find out, establish how severe it is, and to confirm. So you have exercise stress echo, which is there. That is the green one, which you see over there. Now, moving on to MR. So this is the one with the big sort of really the big fellow here in the room. So the MR is the one. So the echo really sort of is the first line again. And what we sort of identify as soon as we start to look at the MR is look at the mechanism. So here you have primary MR, which is the leaflet problem. So you can see a flail leaflet over there. And then you have the secondary MRs. So secondary MRs, you have the ventricular dilatation, which is causing the MR. And on the other side, you have the atrial dilatation, which is causing the MR. And echo is fairly good at identifying these two, the three entities here. And in terms of severity, there are a lot of parameters, but the ones which are frequently used are these, which you see now and then. So the vena contracta, PISA is much talked about, so still very in a limited way. And the other parameters, they all have the limitations. So sometimes there are situations where we are not very sure, and it can be a challenge. And what has really been a game changer and changed the entire the horizon, the flow, the sort of to look at the perspective of the T itself is the 3D. So you can see the excellent images that are provided, and this is where it has really made a difference. So you can look at individual segments, you can look at the anatomy very clearly, you can look at both from the atrial side as well as the ventricular side, and you can look at the regurgitation as to where exactly it is coming from. So you can pinpoint it, I can use the NPR, and you can isolate it, and you can have exact sort of the vena contracta area also. And we have these newer ones, the glass view. So we still sort of are trying to find out how beneficial it is, but that is how the 3D is going in terms of T. And there are these quantification tools which are there. So a lot of geometrical measurements. So this again is available, but again in very limited sort of utilization. And again, this is better, sort of more accurate when it is done with a 3D TE. And you can see that there are multiple measurements. So both in terms of the annulus, the leaflets, the coaptation, in a lot of measurements, a whole host of measurements are provided here. And when it comes to the surgical decisions, echo is the one which sort of decides on surgical decisions, and in terms of whether a repair needs to be made or a valve replacement needs to be done. And also it can predict on the outcome, so how good the outcome is going to be. And once it is done, the surgery, so again, as you can see here, the post-operative imaging, the colorful, the red map, the hot map, if I have to call it. So you can see a lot of greens over there. So that is transthoracic echo. So echo stands right in the front in terms of trying to assess post-operative imaging. And this is the typical sort of algorithm here. So I'm not going to go into details here. So this I will show with the other lesions also. Primarily, it is sort of trying to find out what is the mechanism in terms of 2D and the various parameters which are available. And based on that, we divide them into mild, moderate, and severe. And then when things don't sort of work out, we sort of look at the T itself. And then beyond that, there is the other imaging modalities in terms of CMR. And then again here, so mitral regurgitation, there are a lot of greens here. So in terms of when it is not possible, so we look at 3D itself. And also exercise stress echo has sort of been shown to be useful. And even dobutamine stress echo, especially in terms of viability, has got its own role here. So this is the scene of echo as far as MR is concerned. Now, moving to AS, it's a different ball game here. So here again, echo is sort of very useful in terms of trying to identify the disease, very good at detecting the disease. So this is a very straightforward patient here, set of images which you see over there. So you can see that there is a left ventricular hypertrophy, the cavity is not dilated, a calcific valve which is not opening well, and then you have the flow which is over there. The gradient's pretty straightforward here. But there are times when things don't, again, there are a lot of complexities. We're all aware of aortic stenosis. So then we look at T as an answer. So in terms of looking at the mitral, the aortic valve area, so 3D T is very useful there. And then you have these other scenarios where you have this low flow, low gradient, and then dobutamine stress echo works out here. So echo again is very much in the forefront. And this is the roadmap as far as looking at aortic stenosis is concerned. You can see that when it comes to diagnosing, you have echo here at this starting point. And then it also gives an insight into the aorta. But of course, we need to go a little beyond to look at more precise measurements of the aorta, where we look at CT and to some extent CN. And echo is also useful in terms of providing information regarding the myocardium in terms of wall motion abnormalities, ejection fraction. And then once we have the diagnosis, then monitoring echo is useful here. And then planning for intervention, of course, very, very limited role as far as echo is concerned. But once the intervention is done in terms of the transcatheter interventions, then again, monitoring, again, echo comes back here. So this is the way echo is sort of useful. And then you have these various possibilities. You can see that when you compare with the other two lesions here, there's not much of role of echo in terms of the aortic stenosis. It is just the 3DT and then the stress echoes which are seen on the other side, while the CMR CT is on the other side over there. Next, we move on to aortic regurgitation. Echo is fairly useful in terms of trying to understand the morphology. For example, if it's a bicuspid which is causing it, or looking at the aortic root, which is the mechanism, or looking at the aorta, ascending aorta. And then again, to some extent, not always, you can identify the proximal, the type A ascending aorta dissection here. And then there are various parameters to look at the quantification of the severity of the AR. And again, this is the roadmap, the same sort of process. I'll not go much into the detail, but again, this tells you that how we should go as far as the algorithm is concerned, 2D, various quantification methods, trying to identify mild, moderate, severe. And we look at if the information is sort of accurate, not accurate, then we move on to T. Then again, here, limited role as far as TT is concerned. But when it comes to 3DT, so it is helpful here. And exercise stress echo can be used to look at discordance when there is a clinical assessment is saying something and then the TT is showing something else. Now let's move on to tricuspid valve here. So tricuspid valve, so there are some very standard views. So this is one view where you see the tricuspid valve, and of course with the advent of 3D, there is really get some really good images. So you can look at it both from the ventricular side as well as the atrial side also. But this again is dependent on the images. So if it's a good image, and that's when things pan out. And then we have T also, which is very useful. So there are a lot of standardized views where we can look at the T in terms of the tricuspid valve. So that's how it works out. Now, when it comes to the use of echo in terms of TR, so especially when you are looking at transcatheter interventions of the tricuspid valve, the role of echo is in terms of looking at the size and function of the right heart, and then looking at the valve per se, it is useful there, looking at the annulus to some extent, and then definitely looking at the TR quantification, severity of TR, especially if it is severe TR, echo is fairly accurate, but when it comes to moderate and mild, it's not so accurate. And of course, intraprocedural guidance, echo is very sort of, the procedure is dependent on the echo itself in terms of T. So again, the same roadmap here, but what new insights in terms of new data which has come is, apart from severe TR, now it is further classified into severe TR, massive TR, and you have torrential TR. So this is based on the vena contractor width, and of course the regurgitant orifice area, the vena contractor area increases, and then of course the regurgitant volume. So these are the sort of new terms which are now being incorporated into severe TR. Now, PSPR, as Dr. Jahan mentioned, so echo is still the first line and still provides a lot of information, but because of the complexity of the interventions and sometimes the windows can be a problem, and it's one of the most difficult valves as far as echo is concerned. So very limited views, but when it does provide information, it provides fairly accurate information. Look at the quality of the valve, and when we are unable to get information by TT, we move on to T, and what you see in the middle row are the T images. So you can look at the valve very closely. You can see a very doming leaflet, restricted leaflet. You can also see the PR over there, and the 3D image shows you how you can look up into the pulmonary artery and look at the pulmonary valve over there. So that's a bicuspid pulmonary valve over there. And then as far as the echo is concerned in terms of stenosis, fairly simple here. So you have very limited parameters, but PR is something which is a little bit of a gray area. So there are many areas where the echo still doesn't have answers in terms of validation of mild, moderate. So that's a problem. But in a broad sense, so most of the time echo is able to provide answers and is enough to diagnose and follow up. But when it comes to complex lesions or transcatheter interventions, then we may have to look beyond echo. And this is how the same sort of algorithm, you can look at the PR here, and again, we look at the T here and then go to CMR if things are not answered. So prosthetic valves, you can see this long list of indications, and everywhere you see that there is transthoracic echo or T, which is the first line imaging. So only when it comes to in terms of leaflet motion, you have CT over here, and when you're looking at the morphology, or that's when the CT comes in. Otherwise, rest of the areas, it is always going to be transthoracic echo and TE here. And just a brief look at structural heart imaging. So you can see that structural heart imaging has become a big sort of area now. And in terms of there are these advantages, disadvantages. So that is when you're looking at CT and T, but the real sort of action takes place in the cath lab, and that's where the echo really plays a big role here. And you can see that both during pre-evaluation in terms of mitral valve repair, and then intra-procedural and also post-procedural, it's all a lot of green sort of areas. And so it is a real sort of frontline imaging tool. And these are some images of how echo looks at in terms of interventions, transcatheter theta interventions. So for the first set of images are prosthetic valve, paravalve leak closure. You can see that the lesion is identified and with color, and then the device is in place. And then that is both pre as well as intra and as well as post. So that's how it can be obtained. And there is mitra clip over there. Again, an invaluable sort of role echo plays for mitra clip, and also valve and valve. So again, this is again, the echo is complementary. So again, we have other imaging modalities also are very useful. And then looking at infective endocarditis has again, a very important role. So more accurate in terms of looking at small vegetations, especially when they are less than 10 millimeters. It is able to measure the vegetations and give information, because clinical decisions are based on that. It's very accurate in terms of leaflet perforation, and then also localizing and identifying paravalve leaks. So that's where TT and T sort of really is useful. So to conclude, folks, so I will sort of leave you with this slide. So you have the echo here, and then you have CMR, CT, and you have this, a lot of varieties in terms of 2D, Doppler, color, and you have these 3-star sort of in a lot of areas. And of course, it has got its limitations. That's where the other imaging modalities come into play, and it is complementary to each other. So this is my final slide, just to show that when it comes to mechanism and severity, when it comes to procedural planning, risk stratification, you have transthoracic echo to this in the center, and only when sort of a certain more information is required, that's when the circle sort of expands. And then as far as echo is concerned, we have stress echo, and then 3D echo, and then you have strain imaging also, and then you have 3DT. So these are the other imaging modalities which help in making echo as a primary imaging tool. Thank you for your kind attention.
Yeah, thank you, Dr. Satish. Wonderful presentation. So just to conclude that, I think the echocardiography will be the first line of investigation in any valvular heart disease. There is no doubt about that. But what is important is when you have a doubt on echocardiography, which the echocardiography is not giving the final answer, and in those cases, you need not hesitate to refer to the cardiac MRI, where it has may be having some advantages, especially for example, post-tetralogy fellow to look for the pulmonary regurgitation. So hope you will agree with that.
Absolutely, totally agree. So there is nothing like this investigation versus that investigation. All the investigations are complementary to each other, and we all sort of try to get the best information for the patient. And definitely, echo has got a lot of limitations, and many times it does not give the full answer. And we are sort of dependent on the MRI, and I have totally agree with your comments.
Okay, thank you. Maybe we can take only one question, Dr. Priya.
We see a lot of Epstein where echo. I mean, the surgeons want the cardiac MR to have absolute gold standard reference values, and so not exactly per se valvular heart disease, but Epstein is where we are.
Yeah, I agree with you. That is congenital heart disease, but yes, it has a big role to play.
Yeah, thank you. Dr. Satish. So we'll move on to the next talk.